I'd like to say thank you to Dr. Meredith Fairs. She is our senior hospital epidemiologist here at the Regina General Hospital, and she's got relationships out throughout the Regina area, and is somebody that's come to agree to speak to us with regards to pathogens of concern, and she's going to introduce us to biohazard Just as a reminder, if you're in WebEx, your phones that you've called in on need to be on mute. And those that are in the telehealth suites, I believe everybody is on mute. Thank you very much. If you have a question, I believe just save your question till the end of the presentation, and we've made sure that there's enough time at the end. So with that, I will turn it over to Meredith, and thanks very much.
Perfect. Thank you, Bob. So everyone, thank you for joining me today for this discussion. And what I'm going to be talking about is the chain of infection and how not only healthcare providers play a role, but also other individuals play a role in the chain of infection, including biohazard billing. So the outline for my presentation will go as follows. I'm first going to talk about the chain of infection to make sure that we all understand what I'm talking about and what pathogens we're concerned about in healthcare settings. Now, another word for pathogens are germs, so I'm going to be using that for the rest of the presentation. We're going to talk about how germs are transmitted in healthcare settings, what we can do to break this chain, and then I'm going to wrap up my presentation with a scenario, including the infamous biohazard billing. But before I dive into my presentation, it's important to note the difference of infection versus colonization. When someone says they're colonized, what they're saying is that they have a germ that is in or on their body, but it's not causing them to be clinically ill. They're not showing signs and symptoms of sickness. Whereas infection, if someone were to say, I have an MRSA infection, they're telling us that the germ is in or on their body and is causing them to have clinical signs of illness, which could be a fever or pus from a wound or even a high white blood cell count. So, what exactly is a chain of infection? And this graph depicts a chain which consists of 6 links or events that have to take place in order for a germ to enter someone, a susceptible individual, and either colonize them or cause an infection. Now, the very first link or event in our chain is the infectious agent or the pathogen or the germ. So this is going to be your bacteria, your virus, your fungus, or even a parasite. The second event that has to occur is the reservoir. So this is the environment that the germ lives. It could be a person, it could be an animal, or it could be out in the environment itself, which could be water or soil, for example. Then the third event is that germ has to exit the reservoir or the environment they're living in. So if it's a person or an animal, they have to leave that person or animal. It could be through urine, feces, or even blood. Then we have to look at the fourth event is how's that germ transmitted, and then how does it enter someone to cause an infection. But the chain of infection isn't just for infection, it's also colonization. We still need these 6 events to take place for someone to be colonized. So for my presentation, I'm actually going to concentrate on 3 of these events or links, and that's the germ itself, how germs are transmitted in healthcare settings, and what we can do to stop them from entering a susceptible individual. And that susceptible individual could be a healthcare worker or even a patient. So what germs are we actually concerned with in healthcare settings? So most everyone will recognize are antibiotic-resistant organisms, which are AROs. And we're concerned about AROs because if they cause an infection in someone, we're really limited in what antibiotics we have available to treat them. So common ones that we've all heard of are methicillin-resistant Staphylococcus aureus, which is MRSA, vancomycin-resistant enterococci, which is VRE, and extended-spectrum beta-lactamase, ESBL. However, in the last couple of years, we've had another ARO that's popped up on our radar that we're concerned about, and it's called carbapenemase-producing organism, or CPO. Now, a note about this particular type of organism. Carbapenems are a class of antibiotics, and they're called the antibiotics of last resort. So if we have someone who has a severe infection caused by an antibiotic-resistant organism, we may have a physician prescribe us a carbapenem. Now, if we have someone who has an invasive infection, let's say a bloodstream infection that's caused by a CPO, 50% of those people will die because of that infection. So it's something we need to be concerned about, and especially here in Saskatchewan. And the reason is this. This was a paper published by our healthcare colleagues in Alberta, specifically Edmonton. And the background on this paper is that in 2012, a woman from Edmonton went to India for a vacation. And unfortunately, she had an accident which resulted in her femur being fractured. So she had to have surgery to repair her fractured femur, and unfortunately developed a surgical site infection very deep at the fracture site. The doctors there tried to treat it, but were unsuccessful. They couldn't get rid of the infection. So she actually discharged herself, flew back to Alberta, and was admitted to a hospital in Edmonton, and because of this infection. And what the doctors determined was this infection was caused by a CPO. Now, over the next 30 days that woman was in the hospital, 5 additional patients came down with the same strain of CPO. 4 of them were colonized. And unfortunately, 1 man did develop an infection and died because of it. So, very important, it's on our radar. And in 2016, we identified the first case of CPO in the province of Saskatchewan. And we've identified 2 other people to date with CPOs. So what pathogens or germs are we concerned about besides AROs in hospital settings? Well, we have other bacteria like Clostridium difficile, Staphylococcus aureus, Pseudomonas aeruginosa, as well as E. coli. We also have to worry about viruses like norovirus and influenza, especially with influenza season coming up very shortly. And we have MERS, which is Middle East Respiratory Syndrome. And in May of 2017, the first case of multi-drug resistant Candida auris, which is a fungus, was identified in a patient in Ontario. So that's now on our radar as well to keep a lookout of in our patient population. So how are these germs or pathogens transmitted in the healthcare setting? So lots of different modes of transmission. One of them is direct contact. So this is when we have physical contact between a person who could be infected or colonized with the germ and a susceptible person. So it could be through touching or contact with blood or other body fluids like urine, feces, and tears, or we actually have direct contact with the body lesions. An example of this would be contact with blood with Ebola virus. That's one way for you to get Ebola. Now, it's important to note that the infected colonized person could be a patient and the susceptible person be the healthcare worker, but it also works the other way around, where the infected colonized individual is the healthcare worker and the susceptible individual is the patient. Another mode of transmission is indirect contact. So that's when you have a susceptible person who becomes infected or colonized because they have contact with a surface that's contaminated. So you really want to think about those environmental surfaces that have high rates of hand touches during the day. So think about your doorknobs and handles, handrails. Elevator buttons are like gold standard for everybody touching them. Tables, beds, and chairs. And when you think about chairs, where are your common hand touch sites? It's going to be the back of that chair where you pull it in and out or on the handles. We have washroom surfaces, we have cups, dishes, cutlery, medical instruments. Think of stethoscopes, monitors, and probes. If you don't happen to work in an inpatient area, but maybe in an office, you still have to worry about your computer, keyboard, and mouse. And think about pens, phones, and office supplies. Think about your cell phone. How many of us actually clean our cell phone on a daily basis? Probably 99.9% of us do not. So an example of this type where you could get a germ or infection would be Norwalk virus. Then we have droplet contact. So these are when germs are transferred from someone who's infected or colonized to a susceptible person. And what happens is this person is coughing, sneezing, they're talking, or we've got medical procedures that results in droplets in the air. And as a susceptible person, I walk in and they enter my eyes or I breathe them in through my nose or my mouth. Now, example of this would be influenza. And we have airborne transmission. So this is when we have droplet nuclei or we have dust particles that will have the germs on them. And they're actually staying in the air for quite some time. They're not settling right away to the ground. So when I go into this area, if they're airborne, I can breathe them in and I can become infected or colonized in my upper and or lower respiratory tracts. An example of this would be tuberculosis. And last but not least, one of our favorite is fecal oral. So this is when we have germs, they enter the body because we're ingesting something that's contaminated. It could be food, it could be water, or we're placing something that's contaminated in our mouth. Think of your hands if you don't wash them. Think of that pen or pencil you chew on while you're working. When it gets inside my digestive system, the germs have a great party, they multiply, and then I shed them from my body through my feces. An perfect example of this would be vancomycin-resistant enterococci, or VRE. And we've had a number of outbreaks at RGH and Pasqua Hospital with VRE, and this is what's happening on our units, is fecal oral transmission among our patient population. So how do we break that chain of infection and colonization? Because remember, it's all the same 6 events that have to occur. First, foremost, simplest way is hand hygiene. We have those signs there for a reason, the alcohol-based hand rub. In some instances, it will not work. For C. difficile, you want to use soap and water, but hand washing is the #1 way to break that chain. Using personal protective equipment, or PPE. We have signage on the door for a reason, so if you're walking around and you see signage, look at the picture, see what the healthcare person in that picture is wearing. That's what you need to don. Respiratory etiquette, making sure if we're coughing or sneezing, we do it into the crook of our arm. If we happen to cough or sneeze in our hands or blow our nose, we immediately wash our hands. Cleaning and disinfection. Our EVS workers have standard work. They know when to clean, how often, and with what. But think about areas where EVS staff may not be responsible for, like your office area. Are you cleaning those, or even your cell phones? Isolation. This works for healthcare workers as well. If you're sick with respiratory or GI symptoms, you should stay at home. For our patients, if they're showing GI symptoms or respiratory symptoms, they should be isolated until they're kind of proven innocent and then can come off of isolation. Antimicrobial stewardship, making sure we have the right drug at the right dose, the right route, and the right duration. If not, prescribing antibiotics carelessly can result in antibiotic-resistant organisms, or it can result in other infections, because taking antibiotics is a risk factor for developing a Clostridium difficile infection. And last but not least is education, not only to healthcare workers, but to patients, visitors, the general public as well, to just let them know that simple elements that we can practice day to day can make a huge difference. Now, before I end my presentation, I've come up with a scenario that kind of puts everything into perspective and brings all the elements that I've just discussed here today. So what we have here is we have any inpatient medical unit in a hospital, and this is Jack. Jack is a patient. He's colonized with VRE. He knows he's colonized. The healthcare workers know, and there's signage on his door that says you should be wearing this PPE when you have direct patient care with him. Now, Jack has to go to the bathroom. He has a bowel movement, but he proceeds to not clean his hands afterwards. So he's contaminated his hands with his own feces that has VRE. He comes back to the bed, and as you can see, he's touching the call button, he's got his sheets, he's got his table, his book. He's contaminating all his environment with VRE. This is his nurse, Jill. Jill kind of pokes her head in to see why Jack is hitting the call button, and she immediately goes in to see what's going on. And unfortunately, she didn't wash her hands when she went in, and she didn't wear the gown and gloves that are required. And as you can see in this picture, she's having direct contact with him as well as his environment, and potentially contaminating herself with VRE. After she's done with Jack, she leaves to go chart her observations. Unfortunately, she did not wash her hands leaving the room, and she takes that VRE and feces into the charting area and to any other environmental surface there that she has touched. As soon as she's finished charting, she's off to the clean supply room because she has to go see her next patient, Isabella, all the while not washing her hands. Now, during this time, we have patient Clevie. Clevie was admitted through the ER. The history on Clevie is that a couple of days ago, she had an infection in her leg. She went to her general practitioner in the community, and he prescribed an antibiotic for her. Unfortunately, he didn't do a wound culture, and the antibiotic he prescribed was not appropriate. Infection got worse, so she had to be admitted. So she's Isabella's roommate for this scenario. This is Dr. Shavago. So he's come into the unit because he needs to do his morning rounds. He comes in, he does not wash his hands, and the first thing he does is he goes over to the charting area to see the medical records on the patients he needs to deal with this morning, to see what has happened overnight and the observations for this morning. Again, because we've already got VRE and possible contamination with feces at that area, he's picking that up as well. So he then goes off to see Jack. He does wear gown and gloves going to see Jack, but he does not wash his hands going in or when he comes out of the room and takes his PPE off. He then goes to see his next two patients, which is Isabella and Clevie, all the while not washing his hands. In the meantime, we have EVS staff in the background, and they are cleaning the environment because it's the time to do so, specifically in the cafeteria as well as all the elevator buttons. Well, after Dr. Shervago is done, he leaves the unit, not washing his hands. He heads down to the cafeteria to get some coffee and some cake. Then he's off to the elevator because he's going up to his office in order to do morning appointments. While he's getting off the elevator, we have our infamous biohazard Billy, who has come to visit his aunt. His mother has brought him to the hospital because he can't go to daycare because, as you can see, he has a respiratory virus. So we're going to bring him to the hospital because I have no one to look after him. And you know, biohazard Billy, he's very frisky and everything like that. So he's touching all the elevator buttons, and then they go to the cafeteria to get him something to eat. And then they go and visit Aunt Isabel while he's spreading the love of his respiratory virus. And of course, he's so young, he doesn't understand hand hygiene, nor does he understand respiratory etiquette. And his mother apparently does not understand isolation. So he's brought everything to the hospital. In the meantime, he gets bored, so he's running around the unit. He goes to the nursing station because that seems a lot of fun, and he's touching and talking to people all there, spreading his respiratory illness. Now, while he's visiting, unfortunately, Clevie starts to develop diarrhea symptoms and severe diarrhea for the next 2 days. Unfortunately, the staff do not realize this right away, so she is not isolated. And the reason she developed the diarrhea was because the antibiotics she was prescribed in the community actually wiped out some of the good flora in her gut, and she developed C. diff. So now she has C. diff diarrhea. She is spreading spores throughout the environment. Clevie does wash her hands, but with alcohol-based hand rub, not soap and water. So for the next 2 days, diarrhea, C. diff spores in the environment, not only to her room and roommate, but she knows Jack. And she hates the hospital food, so she's down in the cafeteria. And she has questions and concerns about her care, so she goes to the nursing station as well. Then we have a nurse who's coming into the room with a clean vital signs machine in order to take vital signs. The first thing she does is take vital signs on Isabella. And because she has to do it on Clevie, and Clevie's in the next bed over, she just turns around and uses the same machine, the same cuff on Clevie. Now, this nurse knows that she needs to clean the equipment, so she's put it into the hallway to run down to get the necessary equipment to clean it when she's called away. Another nurse is wandering the hallway looking for a machine because she needs to do vital signs check on her patient, sees one in the hallway, thinks it's clean, grabs it, and uses it on Jack. Now, this is Jack's family because here at, throughout Saskatchewan, we have visiting hours at all time. Jack's entire family has decided to visit him. Unbeknownst to Jack or anybody else, his nephew George, and George does not know this, is colonized with the MRSA. So everybody comes into the hospital. They all go by the hand washing signs and signage, not washing their hands. They go to the elevator in order to go to the cafeteria before they go see Jack. And of course, they're visiting with him, sitting on his bed, holding his hands. And, you know, before they leave, do they wash their hands? Absolutely not. So MRSA is going into the room, and it's possible VRE is coming out of the room to another family member. And of course, since they have concerns or questions regarding their care, they all head to the nursing station as well to get some answers. Now, this is Suki. Suki is a service aide worker on this unit. She's just started her shift. She came in, she washed her hands, but she immediately goes to the nursing station to see what's going on for communication, and then immediately goes to the cafeteria, but doesn't wash her hands before leaving the unit or when she comes back to the unit. And during the day, she's between the nursing station and the clean supply room, stocking and organizing. And then we have Jojo. Jojo is our therapy dog. He comes in to see the patients every Thursday afternoon. Well, who sees Jojo and falls in love? Biohazard Billy. So Biohazard Billy is now on Jojo, spreading the respiratory illness love, and his mother pries him off of Jojo, and then Jojo goes on her way to see other patients on the unit. So as you can see in this scenario, we have a number of players, a number of modes of transmission, a number of factors that all have to happen in order for a germ to be transmitted and then possibly someone to become colonized or affected, whether it's a patient or a healthcare worker. So the next time you're upstairs and a lot of things are going on, just think back to that the slide before this one where you break that chain. Simple elements. What could we have done here to stop some of these transmission arrows? Very simply, hand hygiene, isolation, PPE, having clean equipment. Sometimes that makes a huge difference. So this brings me to the end of my presentation. I want to thank you all for coming and listening to me. Are there any questions at this time?
Hi.
Hi.
I have a question from Esteban. How long do you think that VRE poop stays on the pen on the chart for? Or does it just continuously get transmitted?
It's probably continuously transmitted. If those medical charts are never washed, then you could just have transmission every day for a whole year. Now, Carrie Singa, do we have cleaning standards for medical records here?
We only do charts upon discharge, so it's...
Okay, some of the nursing staff who's here on units, do you regularly clean medical charts? I'm getting a nod. How often?
Every shift.
Oh, every shift. I love it. So perfect. And for pens, they don't last that long, but I wouldn't be sticking them in your mouth. Any other questions? Well, I did include an extra slide because I think it's interesting where when we started asking here at RGH and Pasco Hospital, do you know who cleans your area? It was a very surprising answer of no, yes, and then multiple people cleaning the same piece of equipment. So what they did here in Regina Pasco Hospital, something known as a sticky note exercise. And you may have heard this, or you may have seen two of our environmental managers talking about this lately. And basically what they did is over a shift, they gave different color stickers. So let's say sticky notes pink go to nurses, unit clerks get blue, environmental services people get yellow. And they went to areas and said, what do you clean? And so as you can see on these pictures, you can see who's cleaning what. Sometimes multiple people cleaned the same piece of equipment, and sometimes pieces of equipment were never getting cleaned. So based on this exercise, they could actually create schedules and standard work saying nursing staff's responsible for this, environmental staff's responsible for this, unit clerks are responsible for this. And one of the nurses asked me, you know what, you should ask people who's cleaning your med carts, because that is a huge surface for contamination. And how often do you clean them? The nurse in the back, how often do your med carts get cleaned?
Wipe the outside of it once a shift.
Okay, once a shift.
Inside in.
And the inside. And when we had one of our VRE outbreaks here at Regina General Hospital back in 2013, the Pyxis machine was covered in VRE, and it was inside the Pyxis machine as well. So it's not just the outside you need to be concerned about, it's the inside as well. So if you ever think, I don't know exactly what's being cleaned in my area, a sticky note exercise, it's quick, limited resources, and it's no cost except for some packs of sticky notes. Jason.
Thank you for the talk. I love your web of interaction there and people sharing their filth with everyone else. And I think it's also important to note that every one of those people leaves the hospital eventually. And so we talk all the time in acute care and about, the importance of hand washing and hand hygiene and all that stuff. And that extends, I think, to your life outside of the hospital, right? Because these people are taking, whether they're colonized, hopefully not infected when they're leaving, but when they're colonized, or little biohazard Billy is going back out to daycare and sharing that with all his friends. It's just that hand hygiene at home to help prevent those things from spreading amongst your family and friends and outside of the world of the hospital.
And that's true. It's true. Like MRSA and C. difficile were originally hospital-associated infections only. We only saw them in hospitalized patients in hospital settings. But then in the 1980s and 90s, we started to see people in the community who had MRSA infections or C. diff infections, and we're like, were you in a hospital? Did you have some type of catheter in place, antibiotics? And they're like, no, nothing. So now these pathogens have actually created a little niche or home in the community, and they're circulating there. Just think about when you go to the ATM machine. Who cleans that ATM machine pad? Nobody. I don't even want to imagine what's on that ATM machine pad. I know at some of the grocery stores you now have those wipes so you can wipe out your handles. I think that's great, especially with influenza season coming up. Little kids sit in the basket there and spray the snot everywhere, basically. So, yes, community, everything. It's not, there's no hard boundaries for these pathogens, okay? So what happens in healthcare can happen into the community as well.
Do you feel, maybe a bit of a on the nose question here, when you're doing these? So I look at this and I'm like, yeah, duh. Like I see that web of interactions. Like, yeah, those are all the places. But I mean, I have a biology background, and that's kind of my world. Do you find when you do these types of presentations, are people surprised to find these things, to learn about the ways that these things can be transmitted, talking like clinical staff and stuff like that? Or do you think people get it and they're just not making it a part of their daily habits?
I think a lot of the clinical staff absolutely get it. I think because they're so busy and what's going around like in Emerge or upstairs on 6F or something like that, it's just like, I've got this and this and this to do. I've got 20-minute break in a 12-hour shift. I've got to get this done so-and-so doesn't fall out of his bed, because I know he will as soon as I turn my back. I find when I throw in the animal part of it, that's kind of an eye-opener for everybody. But I have presented this to some patient groups, and now they understand it. They didn't understand it before. People with a biology or healthcare background don't really understand it, but when I show them that awful scenario with biohazard Billy, they get it now. And I feel that a lot more people are asking their healthcare providers, can you wash your hands? Or even coming home from the grocery store or the ATM machine, I think a lot of people now are, oh yeah, I saw Meredith's presentation, I better wash my hands because that's disgusting. Sarah.
Hi, I'm Sarah. I'm one of the infection control practitioners here. I think one of the safest things, or one of the things that we can do to keep our patients safe, is present to them the importance of washing their hands. Healthcare providers washing their hands is one piece of it, but they're out often sharing bathrooms, sharing door handles, light switches, touching railings in the hallway. I think people kind of presume that hospitals are safe places where you come to get well, instead of knowing that there's a lot of threats, and reviewing the technique with them too, because I find a lot of people don't actually know how to wash their hands. You need to saturate your hands with enough hand sanitizer to keep them moisture or like wet for 15 to 20 seconds. They need to use friction, like a good vigorous rub, and get all the surfaces on the hand, because just rinsing your hands with a little bit of water or hand sanitizer isn't going to do anything.
Thank you. Anybody else?
I want to pick up on that too, because I think that's a very interesting point about the amount of time. It's not enough to just squirt your hands with one thing and rub it on the palms and you're good to go. And so there was a recent paper just published in August here, which I'm actually presenting at the ID rounds, research rounds next week, but it's relevant to this. So it talks about VRE infections and the fact that they're actually becoming, there was a study in Australia that found that their VRE infections are actually becoming, or the bacteria are becoming more and more resistant to the alcohol in the hand sanitizer. So it's that even that on its own might not be enough to help protect you, the patient, the healthcare worker. So following those regulations about the amount of time you need that exposure is very key. And I think that's a piece that is often missed for people, and saying that as someone who has, school-age kids, where it's like, oh, he goes up and washes his hands and he sprays some water on it and he shakes them off and then, he's good to go. And it's like, well, that's not actually properly washing your hands, and getting people to understand that I think is a key point too. So.
And it's actually the friction. That's what we're after so much. It's not so much is it alcohol-based or it's soap and water. Soap and water would be our gold standard. But unfortunately, we know at RGH and Pasco hospitals, we can't put a sink everywhere. That's just never going to happen at this point in time unless we get a new hospital. So it is that friction, that rubbing, that helps to get these pathogens off your hands. And I also want to call out a thank you to one of the healthcare workers in Estevan who practiced respiratory etiquette while I was looking at her. And she coughed and sneezed into her elbow. I appreciate that. And I see someone vigorously cleaning their hands in Estevan as well. Thank you so much. Okay, we're good, Bob? Okay, you guys have a great day. Thank you.